I asked Dr. Karlstad to talk. Um, she is a board-certified child and adolescent psychiatrist practicing in Vernon Memorial Healthcare in Viroqua. She also works with patients directly in the Driftless area. She works with the Wisconsin Child Psychiatry Consultation Program and to help support primary care providers throughout Wisconsin as they care for youth with mental health concerns.
Thank you, Lynn. Yeah, so that's me in a nutshell. I have a little bit of a PowerPoint, so I'm going to share my screen. Before I do that, I'm going to talk about teenagers and mental health, and it's not super long. If anybody has questions, feel free to unmute or do the little hand raising Zoom thing, which I hopefully will see. Or you can put a question in the chat to everybody, or you can send it just to me. And then when we're done, I'm happy to take any questions. So I tried to keep it brief, so I'm not going to be able to, like, obviously teenagers and mental health, I'm not going to cover in one session. But yeah, so feel free to keep it a little informal, interrupt me, and ask questions as we go. So first though, maybe, do you guys see just the one slide, or do you see the presentation view? Like, do you see where I have notes, or do you just see one slide?
We see where it says notes and a little slide above that, and then a big slide to the left.
All right, 1 second. There, better?
Yep, that looks good.
All right. Okay, so yeah, so I'm Martha Karlstad. I'm a physician who specializes in child and adolescent psychiatry, and I'm down in Viroqua. So I'm gonna move your beautiful faces so that I can see what I'm doing here. There we go. So in order to talk about teenagers and mental health issues, we have to talk about what is normal teenage experiences and behaviors. And so that's where I'm going to start. Teenagers developmentally and very normally are more willing to take risks than adults and even some children. A little bit more novelty seeking, which means looking for new kinds of experiences. It's also developmentally normal for teenagers to think about their identity. They're trying to figure out who they are separate from their family of origin, who they are in society at large. So trying on different ways to dress, different appearances, but also different political ideas and value systems. Like the whole identity thing is just a really normal exploration for teenagers. The other thing that can go with that is body image issues. And so there's a lot more awareness through the teenage years of what my body looks like, how that fits into societal norms, how that fits into being perceived as, you know, whatever, right? There's just a lot of things with body image that start to come up normally through the teenage years. The other thing is that social connection becomes a really important thing in the teenage years, which can includes a lot of friendship stuff, but also dating and romance and that kind of thing. It's very normal developmentally for teenagers to prefer to be around peers and to socialize with peers over family and family unit, which can be kind of hard for parents, but it's also super normal. It's also developmentally normal to want to stay up later and sleep in. There's actually a brain explanation for that. So through the adolescent years, there's a decrease in the amount of melatonin that the brain naturally produces at night to tell you that you're tired. And so we do see that leads to kind of this night owl thing that happens in the teenage years. It's pretty typical, pretty normal. So then, what are some warning signs? So what gets you outside of of normal, what should make you be worried, and what should trigger some the need for maybe getting some extra help on board. So number one, any kind of self-harm or suicidal thoughts is not normal. And you should pay attention to that and increase support and potentially get, talk therapy on board with any kind of self-harm or suicidal thoughts. It's not necessarily uncommon, but it's not normal. The next thing on here is we are in a very sort of diet, nutrition focused culture. It's really normal for there to be some like dieting or changing the way, becoming a vegetarian, those kinds of things. But if a teenager is not eating for large periods of time, if they're making themselves throw up, if they're weighing themselves every single day, just being really rigid and going overboard, that is a cause for concern. One of the things we know that happened through the pandemic is an increase in eating disorder diagnoses. Some theories about why that is, but that these are things that shouldn't be ignored. They can be medically dangerous, and they can go from being like sort of normal dieting to very problematic and dangerous within like 3 to 6 months in some cases when it comes to anorexia. Isolation, so a little bit more spending their time alone in the room is normal, but like isolating from peers and family, just wanting to be alone all the time, that's not normal. We know that teenagers have some experimentation with drinking alcohol, maybe trying marijuana, but drinking alone, excessive drinking, those are not normal. Drinking to the point of blacking out, those kinds of things, that's not something to ignore. And then school refusal, like going from being willing to go to school and doing okay in school to all of a sudden not wanting to go or failing, or any kind of sudden large behavior change. Those are other warning signs that a teenager needs more help. Worry and sadness are normal human experiences. They get a little more intense for some people through the teenage years and other developmental stages. But anxiety and depression are also the most common mental health issues that teenagers face. And so that's kind of why we need to go through like what's normal and what's not normal. Because anxiety and depression are very, very treatable, especially when they're detected early. Often early detection and just some talk therapy, increasing supports and social connection can be sufficient. And one of the reasons why early detection and getting kids plugged into treatment is so important is that suicide has become the second leading cause of death for children aged 12 to 17 in the United States. Number 1 is car accidents. Number 3 is homicides. Thankfully, kids aged 12 to 17 don't typically have a lot of medical issues and don't, so that it's uncommon that they die. But suicide is preventable. And early detection, treating depression, treating substance use disorders, these are things that we know can help prevent a permanent solution to a temporary problem for youth. So I'm going to talk a little bit about the pandemic. There's a lot that we're not going to know for a couple of years as far as like, it's just hard when you're in the middle of something to really say what the impact of this thing is. But there's been a lot in the news. We are in a crisis for youth mental health. We have been we've not been doing well for the last 10 or 15 years. And so pre-pandemic, things were not good. And then the pandemic has obviously been a stressor on multiple levels for all of us. And our teenagers and our children are no exception to that. But I want to point something out because there's a way that things can kind of get the sort of oversimplified in news reports. And so when we look at just this issue of, so these, I'm going to show you 2 slides, and this comes from large surveys. So we're talking like around 7,000 kids aged 12 to 17 in the United States. Every year there's these surveys that go out. And so this is the data from before the pandemic, 2018 to 2019. And just looking at 3 of the questions on that one. So it's asking people to self-report if they have, in this time frame, seriously considered attempting suicide, made a plan to kill themselves, or attempted suicide. So if you look at seriously considered, it's 18.8%, and actually had a suicide attempt, it's 8.9%. So pretty specific. So I'm going to go back and forth here. So if you look at the first 6 months of 2021, so seriously considered suicide attempt pre-pandemic, 18.8%. During 2021, 19.9%. If you look at actually tried to kill themselves, 8.9% to 9%. So not as much movement as you would think, knowing that we've had an increase in ER visits for suicidality, and that's been in the news a ton. Now, when you look at the studies looking at the increased visits to the ER, they're talking about suicidality or presumed suicide attempts. So they included ER visits for self-harm, whereas in these self-reports, they're specifically asking these kids about, have you tried to kill yourself? And what we know just in general about the research that we've done on how you talk to kids about like suicidal thoughts, suicidal plans is that, and self-harm is that not all self-harm is a suicide attempt. And so we definitely know that ER visits are been up. We know that kids are in more distress. There's more anxiety, there's grief, there's increase in eating disorders. But time will tell how that bears out on suicide specifically. So yes, there's been an increase in distress and increased need for services. But time will tell how that actually impacts youth suicide. And suicide rates for youth have been slowly increasing since 2004, and in 2019 had reached a peak. They actually went down slightly in 2020. We don't have the 2021 data because it takes 6 to 9 months to really sort that out once you're in a new year. So we'll see, but that's a pretty big deal. Looks like I might have. So one of the questions is, how accurate are the responses on the self-reports? Do people still underreport? Do some embellish? Yes, some people underreport and some people embellish. The thing about these self-reports is that because they're done every year across the entire country, you're at least comparing similar distribution. And what we know is that people are actually pretty willing to talk about if they're suicidal, especially if it's something where they're private. But not everybody is forthcoming. But yeah, no, it's hard to know exactly, is this 100% like this is what it is? It's probably a little bit fuzzy, but comparing pre-pandemic to in the middle of the pandemic, you're at least looking at the same kind of data gathering or amongst the same demographic across the United States. And it's a far lower number of people who actually, of kids this age who actually die by suicide, because even looking back here, back at the previous slide, only 2.5% of those reported that they needed medical intervention. And so even though it's the second leading cause of death in this age group, it's still thankfully not a larger number than it is. Okay. So part of the 2021 survey also looked at the connection as a protective factor. And what was really interesting about that is that they added these two questions. One is asking students who felt, if they felt close to people at school and agree or not agree, and students who were virtually connected to others. So not in person, but in virtual platforms. And then how that impacted the responses to the questions about sadness, hopelessness, poor mental health, considering suicide and attempting suicide. And what they found is that either being close to somebody at school or virtually were both protective. So they don't cure it. Obviously, you still have positive responses there, but they are both protective. And what we keep finding is that even though virtual platforms and social media has there are problems and it's not always supportive and kind, but that positive social experiences in the virtual world and social media have a similar impact for teenagers as those kinds of experiences in the real world. It's also the converse is true. So negative experiences in virtual platforms have the same kind of impact as negative experiences in the real world. But I think it's important to note through the pandemic, some people only had the virtual means for connection. And this is heartening that to see that it really does seem to be helpful. So I'm going to just briefly talk a little bit, because whenever I bring up suicide, I want to give people some advice, like how do we work on prevention here? So if you have anybody in your family, or if you're working with a household where there's somebody who is having suicidal thoughts, how we know to help prevent suicide, the number one intervention is to reduce access to lethal means. So there's usually not a lot of time. It's pretty impulsive between deciding to kill yourself and acting on it. So the harder it is to get the means to kill yourself, the less likely it is that you will complete the suicide. So no firearms in the home is the safest through the crisis. Not everybody agrees to that, and they'll just keep them locked up, but the safest is just to not have them there, have somebody else hold on to them until the crisis is passed. Limiting access to medications and limiting access to sharps. The other thing in particular with teenagers is to increase supervision. I had somebody this morning who the reason that they hadn't tried to kill themselves over the weekend is their parents had increased supervision and they didn't have an opportunity. And I was like, that's a success. I am so glad that that is what happened this weekend. So you keeping doors open, adult present when there are peers there, just, you're just keeping a closer eye, keeping more supervision. And the other thing is that families really need to know, how do you get more help if this worsens? So crisis numbers, 911, 211, making sure they know to go to the closest emergency room. Don't drive to the one across town because that's the one you like better. Just go to the one that's nearest to you. This is a genuine emergency. And so when folks have teenagers and they are struggling with depression, they're struggling with anxiety, they're struggling with something, they need more help. A lot of people don't know how to navigate systems. And some of these are kind of separated, but the first thing to do is just talk to the primary care provider. They can refer to services, they can give you ideas, but they're also the first line if the teenager is struggling enough that a medication is warranted. Primary care providers are usually the ones that start them. They may get a referral to somebody like me, but generally primary care is that first line. And then the other thing is talk therapy. Talk therapy is typically the first intervention for the anxiety, depression, eating disorder, substance use disorder. And so you can go online. Psychology Today has a therapist finder. You can put in your zip code, your insurance, the kind of problem, and look around. There are some other things, but then there's, and I'm going to try to get this to pull up for you. There's a new resource in Wisconsin through the DHS. Can you see that? Anyway, it's called the Well Badger Resource. And let's see, can you see it now? No? Okay. Well, it is it's wellbadger.org, and it is Wisconsin DHS. It has a little text bar. You can search, like teen counseling, and then you can narrow it down to your area. But they also have a phone number and you can talk to somebody. They're building it. So they have it mostly built, but they don't have everybody in it. And so if you notice that something's not in there, you can ask them to add it. But they do have people who will also answer the phone and kind of help you navigate that. So whether it's like autism resources, inpatient addiction, outpatient addiction, you put it in the search bar and see what you get. We can't create resources that don't exist. But sometimes it does take a little bit of calling around and doing some investigating, and you can find it. If you're looking for substance abuse treatment, SAMHSA has a phone number, and online they have a treatment services locator where you can put in your area and it'll pull up who does addictions treatment in your area, or you can call and talk to them. Okay, so if you have a teenager that you're working with or in your life who is struggling, and you're just a regular person and not a mental health professional, how can you be helpful? Well, number one, anybody involved in that teenager's life, if you're going to be helpful, you need to attend to your own well-being and your own mental health. That helps you be more emotionally regulated, less reactive, more able to be there for somebody who is struggling. We know that parents, sometimes just having the parents engage in mental health treatment improves the outcomes and the mental well-being for their children, because families are not like autonomous agents. They're like a symbiosis. They all kind of are part and parcel together. But even for, like therapists and psychiatrists, we're encouraged to seek our own treatment so that we are, emotionally well enough to do the care and the work that we do. Okay. The next, listen without automatically offering solutions. A lot of times teenagers just want to be heard. They want to know that they're understood. Staying curious and staying open in and of itself is an incredibly powerful intervention when interacting with teenagers who are struggling. Teenagers can also kind of shut down and not want to communicate. Keep the doors of communication open. Ask questions. How does this make you feel? How you doing? Looks like you're having a hard time. Just those little things to kind of pepper in there, because you never know when you're going to hit that moment where they really do want to talk and they take you up on it. So keep inviting them into the conversation, even if they're, not there yet. Be mindful of stressors. And so being overscheduled, being overbooked, watching too much news, being on social media too much, just be mindful and try to, help limit them. And then last, but usually the most important one that I start with, I don't know why I put it on last on this list, but keep a routine. So consistency, knowing what to expect helps reduce everybody's anxiety. Regular nutrition doesn't have to be perfect nutrition, but eating on a regular basis helps us all. Activity and then rest. We have a crisis of poor sleep in this country, and teenagers in particular. So you probably, if you're here at a NAMI meeting, you've heard about the adverse childhood experiences data. And we don't have as much research yet into protective childhood experiences, but we've started to, and I think this is super, super important work. So I'm going to end by talking through the list of what we're looking at as being like important childhood experiences to help build resiliency and to help children be able to face and navigate adversity successfully. So having a caregiver who loves them unconditionally, and you don't have to have all of these, but these are the factors that we think are really important to building resiliency. And so the more you have, the better, but you don't have to have all of them to have well-being. Caregivers who love them unconditionally, at least one best friend. So you don't need a lot of friends. And more it's looking like just having one person who really gets you is sufficient for most of us. Clear routines and rules that helps decrease anxiety, knowing what to expect, knowing what's going to happen, super important. Active membership in a civic group or faith-based youth group, an engaging hobby, an adult other than a parent that they can trust, a home that is clean and safe with enough food to eat. I want to emphasize, clean does not mean the cleanest house. It means clean enough that you're not at risk of getting sick from hygiene issues. Like I put the bar pretty low, but a generally clean home, a safe home. There's enough food. Involvement in organized sport groups, and it's looking like maybe team sports might be a little bit even better than other sports, but organized sports. Regular opportunities to help others. It's incredibly meaningful for everybody, not just adults. And a school that provides sufficient resources for academic experiences to learn. And so there's a lot there. And as I was going through this and putting it together, I was like, there's a handful of these that were like clearly impacted by the pandemic, some more than others. But there are a lot of these here that like, even through all of the stress and the disruption and the existential sort of stress that COVID has put on us, that we can support and bolster and build for our youth and each other. And And then if you know any teenagers 16 to 18 who are struggling with mental health issues, the National Institute of Mental Health is having an essay contest. Those are due by the end of this month. So I'm not giving you a lot of notice, but that's a really cool opportunity. So if you know anybody, the NIMH is doing that. And then I always like to end with like just people knowing 911, 211, 800-273-TALK. Anybody's in a crisis, these are some resources. So any questions or comments? Or just ask me anything.
Martha, as a psychiatrist, what sorts of medication interventions do you typically use when you're working with a team?
Yeah, I can answer that. Thanks, Paul.
Sure.
Common things being common, generally when I'm working with teenagers, it's usually depression and or anxiety. And depression and anxiety, if it's mild to moderate, can just be treated with talk therapy alone. Cognitive behavioral therapy is the best data, but working with a therapist is often sufficient with mild to moderate cases. When it gets into moderate to severe, the higher risk cases, that's when medication can be really useful in conjunction with therapy. The talk therapy, especially through the adolescent years with development and learning, is really critical. Just like learning how to evaluate your thoughts, to think critically, coping skills, all of that's already happening through those years. And so getting some like expert consultation on how to learn that and do that better through depression and anxiety is super important. But the first line medications for depression and anxiety are in a class called the selective serotonin reuptake inhibitors, or SSRIs. Those are pretty commonly known. So fluoxetine, which is Prozac, sertraline, which is Zoloft, escitalopram, which is Lexapro, that class of medications that has the best data, especially going back into the 90s even, for being safe and effective to help treat depression and anxiety. And so which one we start with kind of depends on the individual picture, family history, and the kind of anxiety and depression they're presenting with. But they've all of the SSRIs have been shown to be helpful for depression and anxiety through the teen years.
Dr. Karlstad, I know a lot of adults that are on medications, and sometimes they feel good and they go off them, and then they, sort of relapse into their issues. How is that with the teenagers? Same,
Yeah.
or are they more likely to stay on their medications better, or what?
Well, I wouldn't say the teenagers are more likely to stay on their medications better. However, they get a little bit more wiggle room. So it depends on the illness in particular. But for depression and anxiety, once you're doing well, we recommend continuing to take the medicine for at least 6 months, but probably closer to 9 to 12 months, and then tapering off. And the reason for that is that the longer that you have in that year of doing well before you taper, the less likely you are to relapse into another episode. And so once you've had 2 or 3 episodes of major depression, we do recommend longer treatment. So after 3 episodes, we do recommend lifelong treatment because the risk of relapse is so much more. But a lot of teenagers, it's a single episode. If they complete the treatment and give them that buffer afterwards, after doing better, there's a pretty good chance that they're not going to have a relapse. Anxiety tends to be a little bit more chronic, which is why the therapy piece is so important, because therapy is a really durable treatment. You learn a lot of skills so that you can handle the anxiety when it comes and it doesn't reach the point of like necessarily needing medicines. Now it depends. Some people have a really severe anxiety and they do end up on medicine long-term, or they end up with relapses. But there's a lot of anxiety disorders in the teenage years that if you really engage in therapy, medicine is a temporary thing. If a teenager develops, so bipolar disorder, which typically presents as depression and then can have more complications with it, that presents in the late teenage years or early 20s. That's a lifelong treatment. That's medicine for life. And if you go off the medicine, it can be pretty serious. Schizophrenia tends to present a little bit later, early 20s to late 20s. So much rarer to see it in the teenagers. But that's another one that that's a lifelong treatment, or you're going to have more relapses and more episodes. So most of what I treat in the teenage years, if the teenager really like engages in the treatment, it's not necessarily a forever thing regarding the medications. Yeah. So, but it can be a little bit challenging to get folks to engage in the treatment because teenagers are busy and they are not independent agents. They're beholden to other people's schedules and routines and transportation and permission and all of that. And so it can be tricky, but most don't want to suffer. They don't want to feel that way.
Okay. Well, does anyone else have any questions for Dr. Karlstad?
Yeah, I have a question. In one of your earlier slides, you talked about a serious self-harm or a suicidal ideation. You know, what is considered serious? Because I've had teenagers who have been self-cutting, self-harming that way, and have had therapists say, oh, they're just seeking attention, you know, it's nothing to worry about. And I just wonder about that. How do you diagnose when it's just attention seeking or if it's something serious you should be concerned about?
Yeah, that's a tricky one. I actually almost took out serious on that and just had to be self-harm and suicidal thoughts, and then I didn't, and I still am not sure if I should have taken it out or not. So lots of things are attention seeking, and something being attention seeking doesn't mean that we don't take it seriously, right? And I think that can get a little confused in the messaging. So attention seeking requires a different approach, but not that it's not taken seriously. So I would start with that. So when if I have a patient who engages in self-harm, I ask them a lot of, like, when I'm first learning this about them, I ask a lot of questions with that sort of open curiosity, because there are sort of different patterns, and not everybody falls into those patterns, but there are a couple of different patterns that are pretty common. One is I tried it because I heard about it and I got a lot of attention. And kids are not necessarily able to like articulate that, but it can kind of come out in how they talk about it. Like there may be a little bit, just a different, maybe evasiveness or like ambivalence. You know, they're not really able to explain it. And sometimes these are kids who accidentally scratch themselves, and then, you know, and typically that kind of attention seeking is not intentional or purposeful. It's a pattern of behavior that's being reinforced. The child doesn't like necessarily even know that that's the pattern that's happening. That's, I would say, that happens sometimes. More commonly, I have a teenager who cut accidentally or heard about cutting, you know, in the ways that teenagers hear about things, and they cut and they found that it calmed them down, that they felt better. And we know that there's a subgroup of people who, when they cut themselves or hurt themselves, biting, scratching, burning, that it releases kind of like, it's almost like it's releasing endorphins, and they actually do have like a calming sensation. And then they learn through practice that like, and for some people, it's like, it is the most effective way to calm down, especially when they're in like an incredible amount of emotional distress. And so in those cases, the reinforcement is that it works. And the treatment is to helping them learn how to replace that unhealthy coping skill with other more adaptive and healthy coping skills, which takes a motivated, you know, client. And and a lot of practice and trial and error, right? But I would say most of the teenagers I work with, they don't want to cut forever. They do want to figure out another way to do it. It's just that nothing is quite as easy and quick, right? And we also know that in those cases, when the teenager, or any patient gets that sensation of calming, when it's actually effective in helping them calm down, that if you tell them not to cut, and they're really trying not to cut, that can increase their distress and increase their risk. And so in times of crisis, like if I have somebody who self-harms and that is a coping skill for them, even though it's not healthy, and they're suicidal, I'm not going to say, and you can't cut. I'm going to say, I don't want you to cut, but like, if that's all you've got, and if it's cut or die, right? And then there are people who cut, who do, they are sort of working up the courage to use that as a method to kill themselves, right? To be able to cut deep enough, to be able to bleed enough. And the only way you know which it is to ask a lot of questions and to be open, to be curious. And it's often a combination. And so I would say it's not uncommon for me to have somebody there's a little bit of all three. There's some attention seeking sometimes, but it does actually work as a coping skill. But then also when they're in a real distress, they do wonder if maybe that would be a successful way to end their life. And so being open and being curious. And then the interventions, I think, is maybe a little bit beyond the scope of this. But the main thing is like, don't overreact and don't underreact. And you're always going to screw it up sometime. But you're trying to like take it seriously, but not freak out, right? And so so if somebody cuts, my first question is, how you doing? Is there something is there something I can do to help support you right now? The other part of that is it's always okay to ask somebody if they are thinking of killing themselves. And we recommend that you ask it directly and you ask it discreetly. So you just say, are you thinking of killing yourself? Specific. You're not going to, like, we have lots of data to show that's not going to help put the idea in somebody's head. It doesn't increase the risk. What it does is it gives them an opportunity to say yes if they are suicidal. And if somebody talks about it, that is protective, and it allows you to help them get help or some emergent care or intervention. And so it is always okay to ask, are you thinking about killing yourself?
Good. Anyone else
Would
have any
you-
questions? Go ahead.
Yeah. When you are working with a teenager, and for those others that are also on this call, what could a parent expect as far as involvement in the therapy? So I think of talk therapy, and sometimes I think that there's some opposition, like a teenager maybe doesn't want things shared with the parents, and the parents, being concerned, maybe want to step in and be a part of the therapy in some way. So how do you navigate that whole confidentiality piece with the teen so that they trust you, but yet you can involve the parents as well?
Mm-hmm. Yeah, that's a great question. It can be really challenging. And when you have a younger teenager, it's a little bit more challenging because there is more needing to involve the parent and in more things, right? And more expectation around that. But part of how I really try to I really try to be forward thinking and pre-planning around this. So if I'm meeting a teenager for the first time, I am talking to the teenager and to the parents or caregivers about confidentiality. And so one, I make sure the teenagers know that if you tell me something that is an immediate risk to your life, that you're going to kill yourself, that somebody is hurting you, I cannot keep that private. I'm not legally allowed to. And so we go through some of that, like you've been assaulted, somebody's hurting you, somebody's touching you inappropriately, you're going to kill yourself, you're going to kill somebody else. That's not something that we can keep private. I'm a physician, so I also have that teenagers are allowed to seek reproductive health care without their parents, like they don't need their parents' consent for that. And so I talk about that in front of the parents and say, like if your teenager has questions about sexual health, they are allowed to ask me those questions, and I don't have to tell you that they asked me those questions. I will often encourage them to talk to their parents about that, and I'll let them know at that time. But this is a safe space for those kind of questions to be asked, and that I take that, responsibility. And I do a similar thing with drugs and alcohol, but we talk a little bit about the gray areas of risk and how, there's sort of like normal trying a beer, and then there's I got blackout drunk and don't remember how I got home. And this one, we're probably just going to tell your parents that day. There's a bunch of stuff in the middle that we're going to talk about how you're going to talk to your parents about that, because we're not going to just keep that a secret forever. So I try to have that kind of conversation up front, to really lay the groundwork in front of both the teenager and the caregiver, so that everybody understands sort of, there are some areas that we cannot keep private. There are some areas that we can, but I'm probably not going to be on board with it, but I'm going to talk to you about it. And we're going to talk about how to talk to your parents about it. And that there are other ththings that we can keep private, so that we all know the categories that those fall into. But then in real world and real practice, it gets real complicated as you're navigating risk taking and teenage issues. And so we often have to check into it again. But sometimes in order to do your best work with teenagers, you're going to undermine trust, because you're going to violate it by getting more helpers involved. And that's okay. And you just work on repair and say, I can't risk your life. I'd rather rebuild your trust, right? And there are times where parents get upset because you haven't told them something and they find out about it. And then, again, it's about having conversations and rebuilding that trust back up. Because teenagers are learning how to be independent. The day they turn 18, they can kick you out of that room and say that you're never allowed to know what I talk about with my doctor again, right? So we really want teenagers to get some practice on talking about things that are really important and hard for them to talk about, before they just get to kick you out of the room. And most parents are able to hear that and work with that. And I think it's important to acknowledge that it can get messy, and that we're all going to do our best to navigate that as safely and responsibly as possible. So it's real. Yeah.
Very good answer. I see the three different categories there, and just navigating that and being really upfront with them. And the totally private, the middle ground, and then nothing private. So I like that conception.
Any other questions?
I have another question. Dr. Karlstad, maybe you can answer this and maybe you can't answer this, but from your work with teens, what do teens want adults in their lives to know about mental health?
Oh, yeah, I don't know that I can answer that, because I think it's probably 10 different things, depending on which demographic of teenager or specific teenager that you're talking about. One of the things that I think is pretty consistent, though, is that teenagers want to be seen as individuals, right? They don't want to be categories. They don't want to be generalized into something. They want to be seen for who they are uniquely in their situation with what they're struggling with. And I think that's valid. I mean, it's a very classic teenage thing to do. But it's also really valid, right? Like they don't want to know about, typically, they want to know from me, if it's this, what does that mean? But from other people, they want to be seen for who they are. They want to be believed when they say, this has been my experience. And so I would say, if you're a parent or a caregiver, that listening with curiosity and being open to the teenager being accurate when they say what their experience is. And yes, sometimes it is embellished or overly dramatized or that kind of thing. But like, if you remember back to being a teenager, that was the real valid experience of being a teenager. Is it felt really big and it felt really like, that's not inaccurate. Just because you have the adult perspective doesn't mean it's not true, right? And so, yeah, I would say believing them when they tell you what their experience is. Mhm. That was a great question. That was a hard one.
Probably a
Okay.
question you can ask your teen patients when.
I might start. Yeah. Just give them a
interesting to
post-it
know their
note.
responses.
Yeah, keep it anonymous. And oh, that's actually great. I'm gonna do that. Thank you, Helen. I'm writing myself a note. I'm doing it.
Good. I taught you something. Okay, any other questions before we adjourn for tonight? Well, if not, again, think of next month. If you're interested, watch for the announcements on our events each Tuesday night, 6 o'clock in May for Mental Health Month. And maybe we'll see some of you watching that. Otherwise, I hope you learned something from Dr. Karlstad. Even though I worked with mental health my entire career, you know, I learned a lot from her tonight. So I was glad that she could present. And I hope all of you were able to take something away as well. So again, Dr. Karlstad, thank you very much for your time and the information you imparted. It was a pleasure to meet you and to hear your presentation. So thank you very much. And if you ever need anything, you'll reach out to NAMI and maybe we can help you if there's a way we can assist you in any way.
Oh, I meant to say something. Thank you so much for having me, by the way. This was delightful. I just wanted to mention that I did medical school in Omaha, Nebraska, and residency and fellowship in Charleston, South Carolina, and both states have really active, engaged NAMI organizations, and NAMI is just phenomenal, and I'm just tickled to be able to participate in a NAMI event because the work is so important. So thank you.
Thank
You want to
have to
become a
again
member
sometime.
for Vernon?
Well, you can recruit her, Lynn. Thank you. All right.
We need more Vernon people.
Again, thank you everyone for joining us tonight. And again, stay safe.
Thanks, Dr. Karlstad.
Thank you,
Thank
Lynn.
you.